Okay. Hello, Summit. Can you hear me?
Hello.
Hey, hi, Summit. How you doing?
Yeah, hi John. How are you? I'm good.
I'm not leaving you alone. Don't look so lonely.
Yeah, I know. I know.
Yeah,
finally,
yeah.
you made it
Yesterday,
today, huh?
well, yesterday was so strange. I've never seen Zoom act like that.
Yeah, I know.
I've used it for 3 years, and
Yeah, because yesterday it was a special problem all over the world. There were many webinars which have been cancelled because
oh,
Zoom
really? It
cannot
wasn't
connect.
just me, huh? I thought it was just
Yeah,
me.
yeah. No. There are many webinars which were. There was another webinar which was I was about to, but then the Zoom crashed, so it was postponed.
Whoa, okay. Well, listen, do you know how to screen share and everything? Do you know how everything works?
Yeah, I think so.
Yeah, go ahead. Let's go over it because we haven't started yet. We won't start for a few minutes.
Yeah. So I'm about to share.
Okay.
Can you see?
Not yet.
John?
Not yet.
Can you see my screen?
Not yet. You have to click the share button. You pick the screen,
Yeah, I
then you
already
click
did.
the share. Okay, try it again.
I did that yesterday.
You'll get it. You'll get it. Takes a little while to get used to. Yeah, I can tell you're not even starting the screen share because watch me. I'm going to do it. Okay. As soon as I click this button, I click the share and there's the 6 screens that open. I pick the screen and I show it to you. So just click on the share screen, then pick a screen to capture the screen. And click share at the bottom of that first screen. Okay, well, the first step, click the share screen. Did you click that?
Yeah, I clicked
Yeah,
that.
click that,
Actually.
and there's 6 screens in front of you. Pick one.
Yeah, there are 6 screens coming.
Yeah, pick one and then click share at the bottom.
Where do I have to click here to share the video?
Well, first, just stop, capture the screen first. Click on the share screen, then pick a screen and then click share. You're not even sharing the screen. Let's get that step done first. You capture the screen. Share screen, open it up,
Actually,
pick a screen.
Share the screen is not coming on my, I don't know why.
It'll come. It always does. There's no hurry. Okay, maybe let's take it step by step, okay?
So maybe I can rejoin the meeting again. Let me, just a minute.
Okay, all right, yeah, try whatever. Okay, we'll be starting in a few minutes. Yuha is going to do webinars. I'm glad to say. Okay, we'll be starting in a few minutes. We weren't the only ones that had problems yesterday. If any of you guys are trying to get in. Daddy K, were you trying to get in yesterday? Hey, Daddy K.
How you doing today?
Good, very good. It worked today. Yesterday, I don't know if you tried to get in, but it wasn't working. Okay, Sunil, you want to try it again?
Yeah, it was all over. It was all over. It wasn't just Neurosurgical TV.
Yeah. I thought it was just my account. I thought something was wrong with my account. Hello, Abdullah. Okay, let's try it again, Summit.
Yeah. So now,
Okay, let's try it again. Okay, yeah, you got it. You got it.
Can you see it now, John?
Yeah, yes, I can.
Okay.
Yes,
Okay,
it is.
Okay.
You want to play the video to test it?
Can you hear me?
Yeah. Can you
Okay.
want to play the video? Do you have a video?
So you tell me when to start. I will start from here.
Okay, do you have a video?
Yes.
Okay, let's play it. Let's test it.
Okay.
And do you have any sound on the video or just a video?
Sound is not important. It's okay.
Okay, good. Okay. So
You see the video playing?
Not yet. Is that a video now?
Yeah.
Okay, there we go. Yeah. We can see it.
Okay.
Okay, that's fine. That's fine. Okay.
Great.
You want to just get off the screen so I can introduce you? Or do you want to stay, or do you want to stay on there? Whatever you want to do. Okay, that's fine. Okay. Very good. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. Today we have the pleasure of having Dr. Summit from India presenting on endoscopic surgery. He'll give you the exact title. And we have a couple of panelists, but we'll go straight away to the presentation. Welcome, Summit. It's all yours.
Well, thank you, John, for this. And thanks for giving me the opportunity to come on this platform and present my experiences about my work here and about this wonderful new modality, new paradigm, I would say, in neurosurgery and spine surgery, which is the keyhole and endoscopic approaches. Now, in the next 1 hour or so, I will be telling you about the intricacies and the technical nuances of this wonderful approach and as to how we can proceed with acquiring the skill set and developing the know-how of these wonderful approaches. So I have no financial disclosures. Well, to define minimally invasive neurosurgery, we all know that they can be done in 3 different ways. One can be pure endoscopic surgery, where we use only endoscope and the instruments are passed through the working channel. And the examples of such type of surgeries are while we do an endoscopic third ventriculostomy, like the surgery for neurocystic cyst or colloid cyst excision, where we use a lot of ventriculoscopic system to perform the surgery procedures, where only and only a pure endoscope is used during the surgical procedures. The other type of surgery is called as endoscopic controlled surgery, where there is no microscope which is used at all and only endoscope is used. And we can have the instruments passed by the side of the scope through a small or a keyhole or a miniature craniotomy. The third and the last surgery is the endoscopic assisted surgery, where the microscope is not the only thing which is used for visualization, but endoscope is also used in between the surgery and after the surgery to remove the remnants of the tumor or the lesion from the corners or the angles which the microscope is unable to see that. So for the keyhole surgery, there are 3 different techniques described so far. One is the endoport surgery, and the other is the keyhole surgery, and the third one is the endonasal surgery. So describing these one by one, the endoport surgery here is done through a small port or a cannula, which is used for deep white matter lesions or intraventricular lesions, like for example, basal ganglia bleeds or lobar hematomas or intraventricular tumors, where you use a small port or a cannula, and through the corticectomy, you do the surgery, inserting the port, and all the instruments are being taken through the port, and you can couple it up with a microscope or an endoscope. The keyhole surgery is also through a miniature craniotomy, and here it is designed to limit the skin incision or the opening of the bone. And then the whole of the surgery is done through the small keyhole. The endonasal surgery is used through the nostril passages or through the paranasal sinuses in order to access the skull base. So one by one, we will see in the coming 1 hour as to how we can use these different approaches in order to enhance our armamentarium of neurosurgical approaches and deal with the different type of lesions. So coming to the first of all endoport surgery, the indications are endoscopic third ventriculostomy, which is a very common operation, which is done by various neurosurgeons worldwide. Septostomy, tumor biopsy, posterior third ventricular tumor biopsy, arachnoid cyst fenestrations, a colloid cyst excision, or a neurocystic cyst excision, or ICH evacuation, or intraventricular tumor excision. And all of these tumors, all of these surgeries, we use a lot of LOTA system, a ventricular scope system, and we insert it through a small craniotomy and through a cannula. And then this is the system which is used for the visualization of the pathology, as well as we take the instruments into inside this LOTA ventricular scope system through the already made channels through this telescopic system. So this is the LOTA ventricular scope, which has got 3 channels. One is the viewing channel, one is the irrigation channel, and the other third channel is to take the instruments through this, where you can dissect, you can take a small scissor inside, you can take the grasper or the punch biopsy forceps inside in order to take a biopsy. And this is the, these two are the silastic cannula, silastic ports which can be fitted into your cortisectomies and which can assist you in retracting the brain tissue in a plastic manner, in a non-traumatic manner. And you can work through this small circular space, a small cylindrical space into the structures deep inside the brain. One such short video of a loculated hydrocephalus. Now, this was a child, 8-year-old child, who came to us with complaints of headache and repeated vomitings. And you can see this is a loculated ventricular system. We took our endoscope and then got a ventricular scope inside the ventricular system. And there, this is the cyst which is communicated with the lateral ventricles. You can see that, and communication was also made with the cisternal spaces. And it was a 15-minute surgery, and the child was asymptomatic absolutely immediately after surgery. It's a small surgery, and it's an effective surgery, and the cyst was effectively drained into the ventricular system. Neurocysticercal cyst, and these are the cysts which now you can see one such cyst which is lying in the ventricle here. I will show you one such cyst which is lying in the ventricle here at the end of the lateral ventricle, and this was approached through the frontal horn here. The ventricular scope ventricular scope is then inserted through the frontal horn and then navigated into the proximity of the neurocysticercal cyst. And you see that the cyst was held by means of a biopsy forceps and was completely removed in a single piece. And now this is a cyst which is beautifully floating inside the ventricular system, and carefully, without rupturing, the cyst was held, and both the cannula as well as the ventricular scope was simultaneously taken outside, because the cyst size was bigger than the lumen of the cannula, and we did not want the cyst to rupture inside the ventricular system. So the cyst has to be taken out en masse, in toto, from the outside, from the ventricles. And there you saw the septostomy procedure being carried out, and there was a membrane at the foramen Monro in the last, which was also broken, and seamless communication was established between the two ventricular systems on the right and the left, as well as the third ventricle at the end of surgery. Intraventricular tumor surgery, yes, I mean, this can be done by an endoscope. Now, this was intraventricular tumor. As you can see, the scope was taken inside, and the scope was taken through the cortisectomy and placed. My assistant was holding the scope, and the instruments, as you see, these are the normal routine general neurosurgical instruments, which were dissecting and decompressing the tumor, and the tumor was removed and piecemeal, and at the end of the surgery, the septostomy was done in order to establish communication with the ventricular pathways. So this is a personal experience of 72 cases operated by endoport technique. This is mainly the experience of last 4 years. And there were 28 endoscopic third ventriculostomies, 12 colloid cysts, multiseptate hydrocephalus arachnoid cyst, intraventricular neurocysticercal cyst, and intraventricular tumors and intracerebral hemorrhages. I have my share of complications with meningitis in 2 patients treated with intravenous antibiotics. Pseudomeningocele develops in 5 cases. Now, with the small incisions, the pseudomeningocele is potentially a big problem, actually, and one should take all the measures how to prevent this complication to happen, because it can be disastrous, especially when the CSF leakage happens in the subcutaneous tissues. Then delayed meningitis can happen, and the CSF leakage from the main wound can happen. And you have to take care of special precautions, especially during the closure of your wound. The dural closure should be watertight. Now, what happens is a small opening, especially when the incision is less than 2 centimeters in size or 1 centimeter in size, you have to be very careful about the dural closure, and it should be watertight. A glue should be used, and you should place a gel foam over the dura in order to ensure solid fibrosis of the wound once the healing happens. And in the post-operative period, for some time, you have to have a crepe bandage or a pressure bandage over the wound, so that until the wound heals, so that the chances of having pseudomeningocele or the CSF leakage, they are minimized as much as possible. One colloid cyst, I have to convert it to a keyhole approach, because this was a big colloid cyst, which was not, although a suitable indication for a Lotta ventricular scope system, and it was then converted to keyhole, and then I had to do it with under microscopic vision, endoscopic assisted. Now, coming to the keyhole approach. Now, this keyhole approach was a concept which was first advocated by Alex Bernatsky, and you can see this gentleman, a legendary, sitting there with me. I had a chance of meeting him when I was in Jordan in 2008, shortly before his sadly demise in 2009. A wonderful legendary neurosurgeon, a keyhole neurosurgeon, endoscopic neurosurgeon, who introduced to the world the concept of keyhole neurosurgery and endoscopic neurosurgery. Also, the concept is not to reduce the size of the craniotomy to the keyhole, but rather to make the minimum craniotomy which is required to access the deep intracranial pathology. Having read both books on the keyhole approaches, and this is here another gentleman, another fine neurosurgeon, comes from Australia, my good friend and mentor, Charlie Teo, who has dedicated his skills to the development of the keyhole brain surgery, and what a neurosurgeon he is. And learning from him and being with him has been a great pleasure for me for the last 7 or 8 years that I have been with him and learning from him. Most of the practice of keyhole brain surgery come from these two gentlemen on this planet, and I dedicate my practice and my learnings from teachings by these great people. Now, coming to the principles of keyhole, what is the keyhole concept? It is very important to understand before you start doing these procedures. And now let's see what is it actually. Now, this keyhole approach is a small opening through which you can see, and this is like looking the entire room through a keyhole. And as you see through the keyhole, you can view the entire room through that small opening, because this is an inverted funnel vision, and you have the vision of the entire wide visual field ahead of you, even through the small opening. So the size of the opening does not matter. When you want to see the entire room, you can visualize the entire room through that small opening called as a keyhole. Now, what is more important in this keyhole is the planning of the incision, planning of the placement of the keyhole, and it has to be absolutely 100% accurate, and hence it has to be done under image guidance vision, under navigation always. And this is mandatory while you plan your craniotomy under image guidance, because the space is limited. And if your keyhole is displaced to even 5 millimeter or 8 millimeter to one or the other side, then you may not get the correct angle of vision, and you will be having a troublesome period and during the entire surgery. Another characteristic of a keyhole is that it has got a mobile viewing trajectory. You have got a wide and multiple angles of vision. You can see through the keyhole from here, from here, from here, from up, from down, and you can have an access to the areas from multiple angles. And this is the beauty of this keyhole, that through a small incision, through a small opening, I mean, you can have various angles of vision, different multiple angles of vision. Now, while planning in the keyhole surgery, planning is the most important, and you have to spend one night before surgery entirely making the planning of the surgery. So how to approach this is a patient which I operated last year, thalamic glioma. Now, how to place the keyhole incision? This is not a question of making a big craniotomy. Now you have to do this tumor through a small 2 centimeter opening. So the best approach is you draw a long axis along the greatest diameter of the tumor, along the long axis. So, and where this long axis correspond or touch the surface of the skull, there is a site of making a keyhole. So this is how you can plan your keyhole to access any lesion. And this is the post-operative scan showing complete tumor removal. On the this scan was done on the immediate post-operative, immediate evening after surgery. Now there are some exceptions to this long axis rule. Exceptions are that when this when some eloquent cortex is coming in the midway between the long axis of your lesion, then of course you cannot go through this eloquent area. You have to modify your keyhole placement and to such an area where which is away from that eloquent cortex, of course. Another characteristic of this keyhole is that which is it's not possible absolutely to visualize the areas which are lying immediately behind the keyhole. So, meaning thereby the lesions which are lying on the surface, the keyhole surgery is not possible for them, and you have to make the opening into the skull as big, as much, at least as big as the size of the lesion is there. So for the convexity meningiomas, keyhole is not the right answer, and you need to make the craniotomy more than the size of the tumor. So this keyhole is beautifully suited, aptly suited for the deeply placed lesions, and should not be tried for the lesions because you will not be able to see that lesion which is hidden behind the margins of the keyhole craniotomy. Now, there are sites where you cannot visualize your lesion, and with the advent of the endoscope, you can have the beauty of this endoscope. Use this tool in order to visualize these specific areas. For example, in an olfactory groove or a cribriform plate meningioma, the area near the crista galli is very difficult from a supraorbital keyhole approach to visualize. So what you can do is, in an olfactory groove meningioma, if you're doing through a keyhole supraorbital approach, you can completely excise the lesion through this, and I'm going to show you this in a short while from now. And at the end of the surgery, you can take in your endoscope and see the attachment at the skull base if there is one, and you can remove this residual tumor along the crista galli or the olfactory plate with the help of an endoscope. Another advantage of a keyhole approach is that the total exposure of the brain tissue in an average craniotomy of 2 by 2 centimeters is only 3.14 centimeters square, and which is very, very less as compared to an exposure provided by the normal conventional craniotomy. And as you all know, that during the long hours of surgery, under the microscopic heat, brain is vulnerable to damage from the heat of the microscope. So the damage to the brain is minimized. So the keyhole approach, any indication, any tumor, any lesion can be removed through the keyhole approach. And you have to just plan the surgery appropriately. Placement of the keyhole is important, and you can take any tumor, any lesion through this keyhole approach. So showing you some of the videos of this. Now this is a supraorbital keyhole. This is a specially placed keyhole, which is suited for certain craniotomies, particularly, which is suited for certain lesions, particularly situated in the anterior cranial fossa base, like olfactory groove meningioma situated in the midline, especially are aptly suited for the supraorbital keyhole approach. Now, one such lesion is olfactory groove meningioma, which was operated by me about some 4 years back. And this is a middle-aged lady, and you can see that the craniotomy was done. This was a 2 by 2 centimeters supraorbital craniotomy, which was lying lateral to the supraorbital nerve. And you see, this is the operative video, and you see the tumor there. And what the beauty of this approach is that you straight away land onto the tumor base, which is one of the principles of meningioma surgery, that you have to attack at tumor base so that the tumor is then devascularized, and then you can take out the rest of the tumor without any problems. So after devascularizing the tumor base, the capsule of the tumor is then coagulated, and you see that nowhere during this entire surgery you feel any compromise in the space, and you can take out the tumor entirely, most of the times without any need for any placement of any retractor on the brain as well. Few things you have to take into mind while doing this approach. You have to be patient. Just immediately after you open the dura, you have to be patient, and then you have to wait for the CSF to egress. be patient, wait for some time, wait for 5 minutes, 10 minutes, drain the CSF from the cisternal spaces, keep on draining the CSF. And once you immediately find that the brain is so lax and the tumor is lying in front of you, immediately on opening the dura, it's a novice surgeon, especially when he starts doing keyhole surgery, may get daunted by the limitation of the space. But as soon as the CSF is let out, whole of the brain becomes so lax that the entire surgery becomes so easy, and just similar to what it is during the conventional craniotomy. You see that the tumor is being decompressed using the CUSA over here, and then the final last bits of the tumor tissue attached to the skull base, anterior cranial fossa base, is then removed, and finally complete tumor removal is then achieved, saving the important neurovascular structures. Another similar case done by supraorbital keyhole approach. Now this was a dermoid and an easy tumor, and you can see that this was lying in the suprasellar area, and this was the size of the skin incision, and a young lady. Now this is the dura which was exposed, and the dural opening is done in a usual manner. Now here, what I do is, what all keyhole neurosurgeons advocate is that while you open the dura, before opening the dura, what you do is that you bevel this margin, Can you see my arrow here? Can you see my arrow over here?
Yes, we can.
John?
Yes, we can see it. Can you hear me okay?
Hello?
Yes, can you hear me okay? Yes, we can see it.
Yes, sir, we can.
John, can you hear me?
Yes,
Yeah,
I
we
can
can.
hear you. Can anybody else hear me?
We can
Yeah,
see
yeah,
it.
we can-
Yes,
we
I
can
can
see
hear
it.
you, John.
Okay, yes, we can see the arrow.
Hello, can anybody hear me? Hello?
I can
Yes.
hear you. Everybody can hear
We can
you.
hear you, sir. Please go on, sir.
Are you hearing me?
Yes, we are hearing you.
Okay, so I was telling you this, that before you open the dura, you have to bevel this margin so as to increase your angle of vision. You drill the inner margin of the bone so that your angle of vision increases by at least 20 to 30 degrees by doing this simple maneuver. And I call this as, Charlie calls this as cheating in the keyhole surgery, because from the outside, you're not increasing the size of the craniotomy, but from the inside, you're increasing the size of the craniotomy and also increasing your angle of vision. I hope you understand that. Sorry. So opening the dura, and then, yeah. So this here you see the pearly white tumor, and this was an epidermoid, and it was taken piecemeal manner, bit by bit. You see important vascular structures over there. You see the carotid artery, and soon you will see this is the optic nerve over there, the carotid artery, and the tumor being taken. This is the third nerve, and the tumor being entirely cleaned from the carotid optic spaces and the carotid oculomotor space and the carotid cisterns. Now, when you take out the tumor, you take your endoscope inside the 30-degree or a 0-degree scope, and then you find more tumor there, and then you can take out the tumor under the endoscopic vision. So at the end of the surgery, you are left with very little amount of residual tumor with the combined vision of the endoscope and the microscope. So this is the beauty of this technique, the combined microscopic and endoscopic approach. And this was the immediate post-op. You see the wonderful cosmetic result. This was a young lady who was about to be married. About 1 month later, was very worried about her surgery, that to a brain surgery. And this was a fantastic cosmetic result which was there. Mini-pterional craniotomy, yes, you require this. The pterional craniotomy is the workhorse of neurosurgeon, and you require these craniotomies in operations like craniopharyngioma. One such patient who was operated by me a few months back. This was a solid cystic craniopharyngioma, and you can see the size of the craniotomy, and the patient walking in the ward 2 days after the surgery when he was shifted up from the ICU. Recurrent craniopharyngioma. Now, this patient came to us as recurrence of the craniopharyngioma. The first operation was done outside some other hospital. And then when he came to us, we chose to do a mini renal when you opened the incision from here to here. And this was, as you see, a multi-compartmental craniopharyngioma, and this is a microscopic vision. And when you take out the tumor, mostly then you take in the endoscope, and then you visualize the wonderful structures seen during the endoscopic vision. This is the pituitary stalk, this is the carotid artery, this is the basilar artery over the brainstem, and you see small specks of the calcified craniopharyngioma tissue, where you can take out under the endoscopic vision. And this is the immediate post-operative CT scan showing maximal tumor removal, which can happen. Medial sphenoid wing meningiomas, yes, mini-renal craniotomy. Now this was one such meningioma which came to me. This is a immediate post-operative CT scan, shows complete tumor excision. And this is the patient which is walking with some support one day after the surgery. And this is, you see the picture of the same patient in the follow-up. The scar is hardly visible during the surgery. Now, I should show you this video, which is mainly important to show you that there is no compromise of the space during this keyhole surgery, as what is generally people believe that the space must be compromised. Now, this is the medial sphenoid. This is another patient, video of another patient. And you see, this is the meningioma tissue encasing the carotid arteries. And the position was supine with head turned 30 to 40 degrees to the left side and extended. And the incision was 4 centimeter curvilinear incision with pterion at the midpoint. Now, this is the frontal dura, patient is supine, and this is the right side. This is the sphenoid bridge, which is first of all drilled. Now, this is the cheating which is being done so as to increase the angle of vision. And the first step is the opening the dura just over the tumor, not the entire dura. In the keyhole, it is very important. If you open the dura over the brain, whole of the brain will bulge out and make your surgery disastrous, and absolutely you will be in absolute trouble. So only open some of the dura, and then when you first of all, after opening the dura, you have to drain the CSF and drain as much of the CSF as you can, because once you do that, you will see that how simple your life becomes and how lax the brain becomes, so that it allows you to work over the tumor and without sometimes even the retraction of over the brain. And then the surgery, the entire surgery follows just as simple as like a conventional craniotomy, peeling the arachnoid over the tumor, then coagulating the tumor capsule, decompressing the tumor through the CUSA. All these steps are similar, and no point of time you require the need to convert it into a larger craniotomy or feel like you are stuck up in a mess. So this is the tumor being removed bit by bit, small piece by piece, decompressing it with a CUSA, and then localizing the carotid artery through image guidance. Now you see this is the optic nerve. This is the olfactory nerve, which is being separated from the tumor tissue, and the tumor being dissected from the right A1. You see, this is the right A1, and the tumor being dissected through the right A1. This is the tumor. This is the middle cerebral artery, and you see slowly sharp dissection is being done in order to remove the tumor from the attachment of the middle cerebral artery, from the attachment to the middle cerebral artery. And probing the carotid artery through by means of a Doppler probe, and this is the ICA bifurcation over here, and the tumor is being slowly dissected. The tumor capsule is being separated from the arachnoid over the ICA, and here the cutting the tentorial attachment of the tumor. and doing a sharp dissection here. And there you see the basilar artery and the perforators and the tumor being separated from the perforators of the basilar artery over here. A sharp dissection here separates without having any possibility of injuring the perforators and the or the basilar artery. So the sharp dissection is very essential in there. There you see the oculomotor nerve. And this is the oculomotor nerve. This is the basilar artery, the tent attachment of the tumor, and this is the carotid artery here. This is the right PCOM going into the basilar artery. So the entire tumor has been lifted up from the basilar artery, and then rest of the tumor will be sucked up, and at the end of the surgery, dissecting here from the middle cerebral artery, the lenticular striates. So you see that the basilar artery and the internal carotid, the MC is over here, the PCOM is here. And the complete tumor removal has been made possible through this small keyhole approach. This is the small remnant of the tumor in the attachment at the skull base, which is now being removed. The last bit of tumor tissue being removed from the right A1. And there you see that a small portion of tumor which is attached to the internal carotid artery was intentionally left behind in the patient, was referred for having a gamma knife radiation later on. Patient was fine doing the last follow-up. Another type of keyhole is the convexity keyhole, which you can use doing the craniotomy for the colloid cyst or glioma. Now, this is the routine glioma surgery, and at the end of the surgery, you can take in your endoscope inside, and then you can visualize the remnants of the tumor tissue and see, and which can aid in complete excision of the tumor. Callosal glioma, a small size of the craniotomy, and you see this is a post-operative scan, and we do a routine volumetric analysis in the post-operative. This was the volume of the tumor tissue which was left behind at the end of the surgery. Thalamic glioma surgery, yes, this was the size of the skin incision you can see here, and small routine keyhole surgery. The post-operative scan showing complete tumor removal. And another thalamic glioma, and this was a post-operative scan. The patient immediately on the first day after the surgery, completely intact and having no neurological deficits. Giant pituitary adenomas, yes, some of the giant pituitary adenomas which are not, I am not comfortable from taking them down from below because of the consistency of the tumor or the anatomy of the sphenoid sinus. I prefer to take them through the over-the-top approach, through the doing a corticectomy and the craniotomy and the corticectomy from above. And you see that this is the post-operative scan, which shows the complete tumor removal. This is the patient coming in my clinic at the first follow-up. And you see the size of the skin incision, which is very small and hardly appreciable after the surgery. Intraventricular tumor surgery, yes, this can be done through the small keyhole here, 2 centimeter keyhole craniotomy, opening the dura and then doing the corticectomy. And this is the tumor over here, visualizing the extent of the tumor with the endoscope before the start of surgery, and then removing the tumor in a usual manner without even the need for retraction at most of the times after the surgery, during the surgery. And removing the tumor piecemeal gives a decompression of the tumor. The only important part in this surgery is to prevent the damage to the thalamus striate vein and internal cerebral veins in the third ventricular system. And you see the tumor is being slowly decompressed and then dissected from this major venous structure. And you see this is the thalamostriate vein, and the tumor is being dissected slowly from this vein, keeping the vein intact. Now take your endoscope inside and visualize, and there you find small amount of tumor residual at 9 o'clock position. And then you remove this small bit of tumor tissue, which is attached to the septal vein in this case, and then complete tumor removal has been achieved at the end of the surgery. Medial tentorial meningiomas, yes, of course, a keyhole craniotomy for them. This is the post-operative scans, complete tumor removal, keyhole cross approach for a pineal region tumor or a falcotentorial region tumor. Of course, this is the size of the skin incision and the patient walking in the first day after the surgery with some support. Falcotentorial meningioma, now I did wish that I should show you this video. These videos are entirely loaded up in my YouTube channel. You can see there. But the purpose of my showing this video was that no sort of tumor is not amenable to a keyhole surgery. Every tumor is amenable to the keyhole surgery, provided you consider the principles of the keyhole approach and understand very well the concepts of this approach. Mini subtemporal Kawase approach. Now, this was one petroclival meningioma, which I did some time back, and this was the size of the craniotomy. And you see, this is the post-operative scan, almost complete tumor removal after doing an anterior petrosectomy by means of a keyhole Kawase approach. This video is already on YouTube, and you can very well see on my YouTube channel anytime. Because of the lack of time, I do have to skip over these videos. Trigeminal schwannoma, yes, again a keyhole craniotomy by subtemporal approach, and you see complete tumor removal, immediate post-operative CT scan, and this was the size of that incision. Beautiful young lady, and this was immediate post-op scan showing no deficit of any sort in the external ocular movements. Retrosigmoid approach, yes, 4 centimeter keyhole approach. Acoustic neuroma or microvascular decompression. You see Teflon patch inserted between the loop of the superior cerebellar artery and the trigeminal nerve in this MVD operation. An acoustic neuroma surgery, yes, keyhole approach, and this was a microscopic vision over here, and you see that the facial nerve with the origin from the brainstem, and here this is the endoscopic view on the lower corner of the slide, and you see the 7th nerve entering into the meatus, and the 5th nerve and the lower cranial nerves. My all videos are uploaded on the YouTube channel so that you can see them anytime you want. Total cases operated, my personal experience, 279, mainly over the last 4 years. And all sort of brain tumor, brain lesions that you can operate on with a keyhole approach. I have my all sort of complications, especially more so during the learning curve of the procedure, and even now so. And now coming to the endonasal surgery, yes, I mean, this is the part and parcel of endoscopic or a minimally invasive neurosurgeon nowadays. This is the minimally accessed, equally invasive directed approach for central skull-based tumors, and this can be an endoscopic pituitary surgery, which is the bread and butter of a minimally invasive surgeon, or can be extended endoscopic approaches as well. And one such is the endoscopic endonasal pituitary adenoma surgery, and this was a pre-operative scan. This is the post-operative scan, and I want to show you this video. And this was a 45-year-old gentleman who complains of often on headache with visual deterioration, came to us, and this was the pre-operative MRI. You see, this is the pituitary adenoma, which was there, and which was chosen to be removed through the endoscopic transnasal route. So many people they take the help of an ENT surgeons along with them in order to help them during the nasal step. But I personally don't prefer. I do the entire nasal step myself. And in this patient, now this is the nasal step, and you should spend some time, decongesting the nasal mucosa, so that it becomes a relatively avascular, atraumatic surgery. Otherwise, what happens is that the nasal mucosa, especially in cases of acromegaly, bleeds profusely, and it makes the surgery very messy. So you have this step should take around some 15-20 minutes before the start of your procedure. Keep them there and adequately soaked in adrenaline and lidocaine, and keep them there inside the nasal cavity for 10 minutes. So that it entirely becomes bloodless field during the surgery. This is the middle turbinate, and then you see the lateralization of the middle turbinate, and this is the superior. This is the middle turbinate there, and you see this is the identification of the sphenoid ostia. This is the sphenoid ostia over there, and the middle turbinate is now lateralized, and medial to the middle turbinate, you see this sphenoid ostia over here. This is the nasal septum over there. Now this is the landmark where where the sphenoidotomy is to be done. This is
Excuse me, Sumit. I think you have another program open on your computer because we're getting some more sound.
How much time do I have?
Oh, no. I think you have a program playing in the background because we're getting some noise.
You're getting some noise?
Yeah. Do you have another program open on your computer?
No, this is my commentary going on in the video, inside the video.
Oh, okay. I'm sorry.
Yeah.
Go ahead. Continue.
Okay. So this marks the anterior limit, the sphenoid ostia of your sphenoidotomy, and then the stripping of the mucosa from the vomer takes place, and you can use your cautery over here, and then finally breaking the attachment of the cartilaginous septum with the bony vomer, so that this is the step in order to become binostril from uninostril, and then this is the keel of the vomer that you see, and the moment you break the cartilaginous septum from the bony septum, you become binostril from the uninostril, and then this mucosa you can burn it, and then you can remove this mucosa from the nasal septum by means of a debrider or the backbite forceps, so that you truly become binostril from here.
This concludes the nasal step.
So the nasal step is concluded, and then you start the sphenoidal step, which is the sphenoidotomy. And you can use your drill in order to complete this step. And then once you are inside the sphenoid, you are removing the sphenoid mucosa, so that there may not become any sphenoid mucosae later on.
Excuse me again, someone. I'm sorry to bother you again. You can mute your video. Try to mute your video.
Yes, John, tell me.
Yeah, just mute your video. You
Okay,
know what I mean?
okay.
You can play the video, but just mute it, okay?
Now it's okay?
But that's good. That's good. Great.
Okay. So, well, sorry for that. So this is the opening of this is the cella. You are right inside the cella after opening the cella floor. Now in this case, the cella floor was already destroyed by means of a tumor, so you can come into direct contact with the dura. This is the cruciate opening of the dura, which you are doing, and then after opening the dura, you remove the tumor, decompression with the pituitary curettes in the usual fashion that you do it in a normal routine transnasal operation. Piecemeal removal of the pituitary tissue is pituitary adenoma is then done by means of pituitary curettes. So then final inspection inside the cella, which is done, and then seen complete tumor resection is achieved. And then finally, you pack this stellar cavity with the fat and a glue. Total 60 cases have been operated mainly in the last 3 years, and I had my share of complications, as I already told you before, and especially in cases of giant pituitary adenomas. And therefore, now my policy is to approach these giant lesions from over the top rather than going from below. However, some authors may disagree with me with my approach, because now this depends on the expertise you have doing an endoscopic surgery. If you are fully confident in doing an beautiful endoscopic operation, I do recommend that those authors are very right in going down from below for the giant pituitary adenomas. But I myself find myself more comfortable in operating these tumors from over the top, because there are more chances of removing this sort of formidable tumor completely. And remember, mind it, when you're operating on a giant pituitary adenoma, your purpose should be to complete tumor removal, especially the supracellular portion of the tumor. Tumor should be removed completely, as complete as possible, because if it is left behind, then post-operative pituitary apoplexy happens, which accounts for a mortality rate of more than 50% in these disastrous tumors. So this completes my my brain operations done through the keyhole. Now, if time permits, I mean, I don't know how much time I do have, especially John.
Well, as long as you want.
Just a minute, John.
As long as
sorry?
you want. As long as you want.
You are too generous.
Okay.
So I will not take much of your time, but I want to show you some of these fine, minimally invasive stuff. And I don't know how many neurosurgeons here with me who do spine in this panel right now with me. Anybody does a spine? Then it is useful to show these procedures. Otherwise, I mean, it depends on the panel. Do you want to see? I just want to hear. If you want to see, then I will proceed with the minimally invasive spine surgery.
Okay. How about the panel? What size? I'd like to hear it, but how about the panel? We need to hear from you guys. Come on.
Yes, sir.
Go ahead, please. Go ahead.
Please go ahead.
Yeah, yes, they all say go ahead.
Okay.
Okay, go ahead,
Okay,
please.
thank you.
Thank you.
So the minimally invasive spine surgery is being done through a series of, there are several retractor systems in the market in place. There are endoscopic tubular retractor systems. Now this is on the screen, which is being marketed by Carl stores, and there you see the telescopes. And this was built by Joachim Ortel, my good friend from Germany. And this has been first devised and first come in 2007. And now he has been coming up with the third generation of the endoscopic tubular retractors. Now this is the tubular retractor through which you take the endoscope, and all the surgery is being done within this tubular retractor with the endoscope mounted over the tubular retractor system. And the whole mounted assembly is right now you're seeing on your screen tops. And this is the tubular retractor system, which is being mounted over by a telescope, and then there is a space by the side of the telescope inside the tubular retractor where you complete your surgery under the telescopic vision. Where you don't use the endoscope, where you use the microscope. There are several tubular retractor systems like this master tubular retractor marketed by Medtronic or by DuPois also are now in market, and then you can take these tubular retractor systems through a small opening into the skin over the area of interest, and then you dock this tubular retractor system and then complete your entire surgery, whatever. Now, having said this, I should say that one level, single level, or at least bi-level surgeries can be done through this single port. If there are multi-level pathologies, then you have to sometimes make 2 or 3 or 4 ports even to complete the entire surgery. But then the more the number of ports, the more time is the procedure takes more and more time. So it is, you have to weigh the advantages of the minimally invasive procedure vis-a-vis the safety of the surgical procedure also. So before you take in and dock the tubular retractor system, you have to cut the skin, and then you have to serially, dilate the muscle, the track in the muscle. You have to stretch the muscle, and then place these tubular retractor systems over the desired site of the pathology. And finally, you in the end, you end up docking the tubular retractor system over the site of the pathology. And this tubular retractor is then attached to a handle, which is attached to the side of the table, so that it does not move during the surgery, as shown in the final picture in this slide. Like this. Now this is the serial dilator systems on the other side, and on one side you are already seeing the masked retractor system in place, and the surgery is done entirely through this small 2 by 2 centimeter opening into the muscle. And now for the placement of this tubular retractor system has to be absolutely accurate, and it has to be guided by an X-ray, because I mean, if you can't afford to be even 1 millimeter off the desired placement on the tubular retractor system. You have to be keep on checking on the X-ray, AP, and lateral view the placement of this retractor system. Now to show you the cervical discectomy, endoscopic posterior cervical discectomy procedure. This is a wonderful procedure. Before I start this video, let me orient you. This is cranial, this is caudal, this is patient's midline, and this is patient's left side. So this was a C5-6 disc, and you see this is a posterolateral disc herniation, and this is the left side of the patient which is being operated on. The tubular retractor is then placed on the patient's left side at C5-6 level. Now this is a bit of a bony work, bony drilling which is being done, and removal of the bit of a lamina and medial 1/3 of the facet, and there you find the ligament flavum there, and there you see the root which is coming, which is bulging with the presence of the disc in front of it. And there, this is the root you see, and anterior to this root lying the complete disc. And soon you see that the anelotomy is being made, and by means of a knife, and then entirely this disc biopsy forceps is then used to remove the disc tissue. And there you see, bingo, the disc tube, the disc material is then coming out, and in totality. And this is a small surgery. This is a 15 or 20, at the most 15 or 20-minute job, and with a small 4 centimeter, small 1 centimeter skin incision. The maximum height of the port which you use in a cervical discectomy is 12 millimeters. So, I mean, this is a wonderful procedure, and absolutely patient becomes pain-free immediately after the surgery, and you can send the patient home the next day. Now this is the total amount of the disc, and this is the size of the skin incision which you see there. Another bread and butter of a minimally invasive spine surgeon is endoscopic lumbar discectomy, and this is the same orientation: cranial side of the patient, caudal side of the patient here. This is the midline, and this is the patient's left side. Patient is being approached from the left side because it is a left-sided disc there, and this is the L4-5. I think this is the L4-5 disc, yes. So partial inferior hemilaminectomy is done, and partial drilling of the very little 10% drilling of the L4-5 facet is being done. You see, this is the dura which is coming, and cutting of the ligament flavum is being done over there. And soon you will be seeing the disc tissue after doing the anelotomy. The disc tissue is being catch hold of with the biopsy forceps, and then the attempt is being done to remove this disc tissue completely in totality, rather than removing it in a piecemeal. Yeah, that's what. So this is also a small surgery, and you can send your patients home the next day after surgery. Now, multi-level lumbar canal stenosis. Yes, you can. I was talking of a multi-level pathology where you can insert your tubular retractors and do the decompression at multiple ports. So this was a similar patient having 4-level canal stenosis, as you can see in the cross section of the MRI images. And there was a loss of lordosis of the lumbar spine also, and patient was having severe back pain, so it required fixation as well. So this was a 2-level decompression done by a single port. This was the master tubular retractor system in place, and you see this is a laminectomy procedure which is being going on, and the entire decompression from root to root is being done at 2 levels through 1 single port. So there were 4 levels. So you require 2 ports, and mind it, you can do a contralateral decompression through a uniportal technique also. So total of 2 ports doing 4-level decompressions on both the sides, you can end up achieving this. And you see that at the end of the procedure, it's been completely decompressed. You see the root decompression. You see the foraminotomy over there also, easily done without any compromise in the feeling compromise in the space at any point of time. And at the end of the surgery, percutaneous screws, they were also done in order to fix the spine, as the patient was complaining of severe back pain. And this is the post-operative photograph. Interbody fusion, yes, I mean, you can do the interbody fusions as well, doing the with the minimally invasive technique, and this is again by means of placement of an tubular retractor system, and which was docked on the patient's right side, and this is a L5S1. Um, now 3 osteotomies are done. I mean, first osteotomy is done, and the second osteotomy. I should show you these osteotomies. Now, this is the important part of the operation. The first osteotomy is done just below the. Now, you have to see it on an X-ray, and in the X-ray, you have to localize the lower border of the L5 pedicle. So this is the site of the first osteotomy of the at this site. The second osteotomy is to be planned at the lamina facet junction over here, as you can see there. And the third osteotomy here is planned just above the superior border of the S1 pedicle. So the idea is to remove the facet, and what are the exact GPS landmarks to remove the facet are earmarked by these 3 osteotomies. So this is the most important part of the operation. And once you do this osteotomy, the whole of the disc space is lying in front of you, and no neural tissue is in front of you. So you can work fearlessly in this zone and work on the disc, work on the interbody space, and do whatever you like. Removal of the inferior articular process after the completion of this osteotomy, and there you are removing the further soft tissue over there. And there you see, this is the L5 exiting route. This is the right L5 exiting route over here. And this is the dura. This is the L5 disc space. Here is the L5 disc space, which is your area of interest. So only neural tissue which you are seeing by chance is this L5 exiting route. Otherwise, this also sometimes is not seen, and you are seeing the whole of the disc space in front of you at the end of your bony work. So rest of the job is similar, just like you do a normal foraminal lumbar interbody fusion. Discectomy is being done, and then end plate preparation is being done, and entire disc space is being prepared, and then placement of an interbody cage is done, and all through the tubular retractor. Now this is the 18 millimeter tubular retractor, and you do the entire skin. Now sometimes what happens is that, especially if in a preoperative MRI, there is canal stenosis also associated with your discal protrusion, then you have to do a canal decompression also with your TLIF procedure. Now this is what I am doing. I am drilling the facet of the L4 of the L5 and S1. Sorry, drilling the spinous process of the L5 and S1, and doing the decompression over the dura of the L5 S1 interspace, so that at the end of the surgery, it looks like this. And not only the removing the spinous process, also done the foraminotomy over here of the S1 root, so that it becomes free. Now see, this is the completed procedure with the bony cage, and then after this you place the percutaneous screws in the L5S1, so that this completes your surgery. This is the immediate on-table X-ray which was done after the surgery. Spinal tumors, intradural extramedullary spinal tumors, yes, this is, you have to dock your tubular retractor system exactly over the site of the IDEM, and then the picture looks like this, and then you are ready to open the dura. You take, before opening the dura, you take the stay sutures on the dura, and then you cut the dura, and then your tumor, your baby is about to be delivered, and then this is it. And you cut the pedicle, coagulate the tumor at places, or maybe even CUSA decompress it, or electively choose to remove it en toto, en masse, and removing the blood supply, the tumor. The entire operation is about to be completed, and removal of the tumor. And then the issue here is the closure of the dura, which is comes with practice, because the space is limited and in depth actually. So you have to use specially designed J-shaped needles in order to close the dura. But with practice, one is able to close the dura without any discomfort. Nowadays, Karl Storz has come with with the staples also, so that you can cluck, and then you completely close the dura within no time. Kyphoplasty procedure also, injection of a cement in a collapsed vertebral body, it can be done, and the patient, this is a wonderful procedure, and the patient becomes symptomatic, symptom-free, pain-free immediately after the surgery when he reaches into the ward. And percutaneous screw placement, yes, I mean, so this is my personal experience. This is 327 minimally invasive spine surgery cases, all sort of cases, lumbar disc, cervical disc, kyphoplasty, where a minimally invasive spine surgery can be used. They are used now. So take-home message is that endoneurosurgery and endospine surgery requires two types of skills. It's a spatial skill set which is developed by repeated practicing, and especially taking part in the cadaver programs, teaching programs, because it requires working in a narrow corridor. It requires endoscopic dissection also, and which is a different hand-eye coordination technique. So these techniques are absolutely safe, and they are a new paradigm in neurosurgery and spine surgery. These are minimally invasive, however, are maximally aggressive to the target, and it certainly reduce the patient morbidity. And however, the learning curve is there, which can be reduced, as I already said, by joining several training programs. So thank you so much for tolerating me for last 1 hour. I hope you enjoyed the session. So if there are any questions, you are more than welcome.
Okay, very, very good. Thank you very much. Very thorough. And I'm sure, I'm just going to get you up the screen. I'm sure there are comments or questions. So the panel, it's open for comments or questions.
Can you hear me? John
Yes.
Bennett?
Yes, Puneet. Hi, how are you?
Sir, I'm fine. Good evening, sir. It was a very nice presentation. Congratulations to you for that. Sir, I was a bit, I was thinking that you, didn't say anything about the foraminoscopy. I mean, the purely endoscopic procedure of the spinal discs. So I would like to know something about that, because we are doing it here. And I would like to know, what do you think about them? Are they inferior? Are they, slightly less?
No, it's not a question. Yeah.
Sir, my question is, what do you think about foraminoscopy as compared to, let us say, the easy go retractors that you have, the Karl Storz retractors? As compared to that, what do you think about the foraminoscopic techniques?
I understood your question. So basically, it is not about the inferiority or the superiority of any operating procedure. We have to see as to what the patient requires. So if if the preoperative MRI says that there is this absolutely foraminal compression, then yes, foraminoscopy is the answer to that pathology. However, these instances are very, very rare, that where only the foramen is narrowed and the canal is not narrowed. So most of the instances, what happens is that 90%, 95%, I would say, that the canal is stenosed, and along with the canal, the foramen also is stenosed. So you end up decompressing the canal, which you require a tubular retractor system for that. And while you're doing that through a uniportal technique, you decompress both the foramens as well on both the sides. But if yes, you are right, if only a foraminal compression is there, then you can do a foraminoscopy as well. It's all a question of planning and seeing carefully the preoperative MRI images and doing the procedure what the patient demands.
Thank you, sir. Thank you very much.
Thank you. And more comments, questions? Don't be afraid. People are quiet today, Sonnet.
They understood everything, I think.
I'm not a neurosurgeon. You did a fellowship with Dr. Teo, or did you go to a course there? Or?
No, I did not go for a fellowship. I just happened to, we meet every year 2 times because he comes to my center and one center in the city in India, and then we do workshops over there.
Oh, good.
Yeah, and then there is one of my another good friend in one city where he comes regularly. He was in fact about to come in September for our course. Unfortunately, because of COVID circumstances, we canceled that course. So probably
Okay.
I may be meeting him maybe next year, February or so.
Well, does he want to do something online? Because if Dr. Teo wants to do something online, we could arrange that.
Yeah.
And when is that conference with Dr. Teo that you normally have? What time of the year? September, you say?
September, yes, September. So September and October, no, these are the 2 months that we used to have where TU comes certainly in September in one city in India, and then during that time, our hospital also, has a workshop with him.
And how long, a 2-day workshop, 3-day workshop, or how
No,
long is it
it's
last?
generally a 3-day workshop, and we used to have live surgical sessions as well as the didactic lecture sessions. So last year we had in September, we operated 2 days. We operated 1.5 day. We operated, and then another 1.5 day for the CME session.
Oh, okay. So obviously hands-on experience is the best.
Yes,
being
yes.
supervised.
Actually, cadavers. When I was in All India Institute, I used to do cadaver sessions as well. But after quitting All India Institute, I mean, getting cadavers is a big problem over here. So, I mean, as you might understand, it's a big problem. It's a difficult thing to get cadavers, especially fresh cadavers. So, getting a hold of cadaver courses, no doubt, they're the best teaching programs available around. But I mean, it's a very difficult job to gather the cadavers.
Yeah, I know in Africa, there's only a couple of cadaver labs. There's not many at all.
Yeah.
There's one in Kenya, I think, of course, Cairo, and I'm sure there are a couple others. Okay, more comments, questions from anybody? Everyone's shy today, Doc.
Any idea, John, how many of them were there?
Well, no, I don't have the accurate Google Analytics, so I really can't figure it out. But okay, Daddy K, go ahead. We have a neurosurgeon from Nigeria.
Yes, Daddy. Hi. How are you doing?
John, we're not shy. I congratulate you. It's a beautiful presentation from ventricular endoscopy to endonasal and then to spine. Spine is evolving, and but apart from cadaver dissections, the major problem is the setup. If you have the tools and setup, then things can go a bit easy. But funding is seriously required in that area. Yes.
Correct. I think, John, I think this is the responsibility of most of the teachers right now to disturbance which is there. Sorry, am I audible? John, you're not audible.
Yeah, I know.
We can hear you. We can hear you.
Yeah, okay. I'm sorry about that.
Yeah. So I was saying that right now there is most of us have the responsibility to develop these teaching platforms, which are hands-on, more so focus on hands-on, like cadaver labs. And I would, advocate the establishment of these cadaver labs all throughout the world, so that more and more younger neurosurgeons get the feel of hands-on. And believe me, there is nothing like, the teaching can be nothing like doing it on a cadaver.
Yeah, okay. Yeah, I understand that. Have you done any of the 3D models? Are they any good? Have you tried any of those?
Yeah, I mean, 3D models, I mean, yes, they are maybe another future state-of-the-art form of teaching modules.
Okay.
But as I say, in our country, even, I mean, there are not many places where these 3D models have been fully developed. So,
Right.
and it's time and resources, I'm talking in terms of financial resources, to develop these 3D models. More easy to get are the cadavers, but cadavers are difficult only from the legal aspect as to here, and it varies from country to country also. In some countries it may be easy. In our country, it's easy at some places to get these cadavers and establish the cadaver labs.
Right.
So when I was in the institute, I established one such cadaver lab, and we used to do routine training programs, and it was a wonderful thing. Many neurosurgeons, get to learn these procedures while doing on cadavers.
Yeah, refrigeration is a big expense, right? For that's a big hindrance to a lot of labs openings. The cost of a huge refrigeration unit.
Yeah.
Any okay, more comments or questions for Sunit? Go
Sir,
ahead.
can you hear me? This is Puneet here.
Go ahead.
My question to Dr. Sumit is, sir, I mean, I was trained in foraminoscopy by Dr. Gore. So, I mean, obviously from the starting, we started from the foraminal discs. But is it possible to remove even the central discs from there, from the foraminal part? I mean, we can take the endoscope, we can make our way through, we can cut the, annulus, and then we can take out the fragment which is going inside and compressing the epidural components. I mean, do you do that, sir, foraminoscopies and all that? And do you believe in that to remove the central
Well,
discs?
if you ask me about the philosophy, I believe in the philosophy. I believe in the philosophy and believe on this that foraminoscopy works. Yes, but I mean, I am of the opinion that every operative procedure has to be done for its indication. So, as I already said, foraminoscopy always works best when it is done for a foraminal indication. Okay.
Okay.
Do you understand that? But having said
Yes,
that,
sir.
it depends on one's expertise also. Like, for
Yes,
example,
yes.
Dr. Gore, he's a super expert in this procedure. He invented this procedure, absolutely. So, I mean, he is the one who is capable of, doing the canal work from the foramen. And people who are as experienced as him are capable of doing the canal work, not me. I'm not capable of doing it. So I do not do this procedure. See, at the end of the day, what matters when you go and lie on your bed, what matters is that your patient should benefit from your surgical procedure. If I'm not comfortable in doing that surgical procedure, or my patient will not get benefit from that surgical procedure, so I don't do it. I don't do the procedure in which I'm not competent enough. So I don't do the canal work from the from the foraminoscopy. I do the canal work from the canal, actually. But yes, having said that, there are people who are expert who can do the canal. I hope you got the answer.
Yes, thank you. Very, very humble and honest of you, sir. Thank you so much.
Thank you.
Abdullah Jamal, how are you doing? I haven't seen you for a while.
Yeah, I'm on lockdown.
Oh, okay. How you doing?
I'm good. Thank you so much, Professor Sumit, for that expose.
Thank you.
In fact, quite interesting. There is this saying, a procedure should be minimally invasive and maximally effective. Yes, because if that is not the case, there will be some difficulty. I agree with you, of course, with other people that commented that it needs proper training and also the availability of instruments because I've had experience with this. It's exciting. It's an exciting field of neurosurgery. Now, I didn't quite look at your chart on the problems or complications. How many occasions, on what occasions were you compelled to convert to open, to a larger or open access neurosurgery?
So this was an expected question at every meeting which I present this keyhole approaches. At the end of the presentation, I'm always asked this question. So I always tell very honestly that maybe I remember one occasion, or maybe at the most 2 occasions, that I required to convert it to a bigger craniotomy, and those were during my very early years of starting doing my keyhole approaches. And one was for the medial sphenoid wing meningioma that I was doing, and another one was for maybe a huge glioma, perhaps. So in both of these instances, the reason for converting was my inability to understand the keyhole concept. This is now how when I relate to, when I think in retrospect as to why I required conversion. I would tell you the point that why I required convergence on those 2 instances was that after having made the keyhole, at one instance, I did not make the keyhole at a perfect location where it has to be made. And remember, this is the number one dictum, number one fundamental principle of a keyhole surgery, that you should always use image guidance, and your keyhole should be perfectly aligned with the long axis of the tumor, where the long axis of the tumor coincides with the skull. So number one dictum is the placement of the keyhole. If your placement is wrong, then you are bound to fail during the entire surgery and bound to take a decision to enlarge your opening. Number two dictum is that immediately after opening the dura, you have not to jump over into the tumor, the approach which is like in a conventional craniotomy. No, this doesn't work in a keyhole surgery. In a keyhole surgery, just immediately after you open the dura, you have to wait. You have to wait. You have to be patient and keep on draining the CSF. Now, as you keep on draining the CSF from the cisternal spaces, after some about 5 minutes or 8 minutes or 9 minutes, you yourself automatically see that the brain becomes lax and sits down. And then the tumor of whatever pathology becomes visible on its own. So in both these instances, when I think back, I was not very competent enough to know these concepts of the keyhole. So I was very impatient, trying to reach the tumor immediately. So I retracted the brain. There is absolutely no need to retract the brain in a keyhole surgery. When I retracted the brain becomes swollen and it more bulged out. I opened the dura over the brain, so the brain bulged out first. So these were all the problems which can happen when you don't follow the keyhole approach concept. So if you follow the keyhole concept, if you follow the fundamentals of keyhole, then absolutely, there is absolutely no chance that these problems might happen, and you might never in life need to convert it into a big hole.
Okay, thank you so much, Professor Smith. As a follow-up to that, you said that the principle is to go along with the long axis of the pathology. Assuming there is a neighboring organ at risk that you have to protect, what do you do? What's the principle behind, how do you go about that? About going along the long axis and first of all going to protect an organ at risk, which might not be in the same axis with the long axis of the tumor.
Well, I said that if you would have in my slide, if of course an eloquent area is lying on the long axis, you will not go to that area, of course. So you have to modify your long axis principle. You have to go from the area where the lesion is still closer to your approach, to your keyhole, but it absolutely avoids the eloquent area. Okay. So you have to abandon your long axis approach in that case.
Oh, thank you so greatly.
Thank you.
Okay, Sunil, do you have any comments or questions? You've been a little quiet. Sunil, you still there from China? Perhaps he stepped away. Okay, any more closing comments, questions? Well, Doc, I'd like to thank you for coming. Very, very complete and very educational for a lot of people that were watching, as well as people in the panel. And we look forward to your next presentation, whenever that is.
Thank you. Thank you so much. And I urge you all to stay safe and stay inside homes and enjoy your lockdowns. Thank you so much.
Okay, very good. We'll end on that. Thank you. Goodbye, everybody.
Goodbye.
Bye-bye. Stop recording. There we go. Stop that.